Bismillahirrahmanirrahim. Today we are going to discuss about diphtheria. It is an acute toxin-mediated disease which is caused by a toxigenic bacteria called Corynebacterium diphtheria. As you all know, it is a very contagious and it is a potentially life-threatening bacterial disease. It is usually a localized infectious disease and usually attacks the throat and nose mucous membrane. So what is the cause? Corynebacterium diphtheria, as you can see, it is an aerobic gram-positive bacillus. As you can see the shape of this bacteria, it is pleomorphic, it is club end, it is non-spore forming, non-acid fast and non-motile. As far as epidemiology is concerned, it is usually transmitted from one person to other person through respiratory tract by small droplets when the patient coughs or sneezes. This bacteria travels through this droplet infection and can go to another person who is standing nearby through nose or mouth. And sometimes transmission may occur from the skin layers of articles which are soiled with the discharge from those patients who are suffering from diphtheria. These toxigenic bacteria, they go into the nasopharynx, they may settle on the skin, they can go into the middle ear or anterior nasal cavity, and they produce a toxin which is the main cause of the disease, which inhibits the cellular protein synthesis. This toxin is responsible for the local tissue destruction and pseudomembrane formation in the throat and oral cavity. The incubation period is 2 to 4 days. It means that first when the bacteria enters into the body, it takes about 2 to 4 days to start its symptoms, and usually the patient comes with history of sore throat, and despite the fever is initially mild, but there is marked tachycardia because it also has systemic manifestations as well. The main diagnostic feature is wash leather elevated grayish green membrane or grayish membrane on the tonsils, or it can be on the palate, soft palate, in the tonsils, in the pharynx, in the larynx. It has a well-defined edges and it is firm and adherent to the tissue, and around it is inflammation. And along with this, there is enlargement of the neck nodes, lymph nodes, which is called lymphadenopathies, and usually the patient has a bull neck like features. In acute infection, there may be membranous tonsillitis, there may be nasal infections, nasal discharge, laryngeal infection, which may present with hoarseness or airway obstruction. There may be skin infection, wound infections, and if the bacteria goes into the eyes, it can cause conjunctiva infection. The complications, main problem with diphtheria is there is very high chance of airway obstruction or laryngeal obstruction or paralysis. Paralysis occurs due to neuropathy when there is damage to the nerves like vagus nerve or recurrent laryngeal nerve. It may cause paralysis of the larynx. The toxin, when it goes into the blood, it goes to the heart and it can cause myocarditis, and it can also cause peripheral neuropathy. Now we come first to pharyngeal diphtheria. It is insidious in onset. Slowly patient develops sore throat with exudative pharyngitis, and slowly the membrane starts forming over the tonsils of the pharynx. It is called a pseudomembrane because it is not a true membrane. So this membrane can cause obstruction of the airway, and there may be death by airway obstruction or asphyxia. Fever is not usually high grade, but patient is very toxic due to systemic symptoms. Now, as you can see in this picture, there is a grayish membrane which is well defined margins, and it is on the soft palate on the left side as well as going onto the tonsils surface. When we peel it off, there is bleeding from under surface, and this is the typical bull neck appearance. The cervical lymph nodes are enlarged, which also cause a threat to the airway, and due to which there may be further compromise of the airway. And what are the distant complications, the systemic complications? As I already told you, there may lead to myocarditis. There may be cardiac arrhythmias in acute phase, or there may be sudden cardiac arrest, sudden death, or due to prolonged damage, there may be arrhythmias. It also damages the nerves. There may be motor neuropathy, paralysis of the soft palate, and eye muscles, limbs, and diaphragms may also be affected later on, and it can resolve it sometime after a few days if the patient survives of the complications. Laryngeal diphtheria is the most dangerous one because, as you know, the larynx is the main entry into the airway. So either this membrane from the tonsils can go down into the larynx and obstruct it, or there may be membrane in the larynx. Patient has mild fever initially, then dyspnea, hoarseness, and a barking cough is seen, and this is a very dangerous situation. It is an acute emergency, and we have to secure the airway as early as possible because it can very rapidly develop airway obstruction and patient can die within few hours or minutes. So we have to take it serious emergency. And you can see on the right side of the picture this white membrane. This is the laryngeal diphtheria. On the left side it is the tonsillar diphtheria. If the diphtheria into anterior nasal cavity, it is called anterior nasal diphtheria. It starts usually in discharge from the nose. Discharge can be mucoid or purulent, and it means it has both mucus as well as pus. Sometimes it is blood stained. A white pseudomembrane usually forms on the nasal septum, and when we peel it off, there will be hemorrhage from below. There may be death from acute circulatory failure within the first 10 days. 25% of the patients may develop myocarditis with arrhythmias and cardiac failure, and neurological involvement is seen in 75% of cases if not treated timely, and usually starts after 10 days, initially by palatal palsy, the paralysis of the palate, soft palate. So there may be generalized polyneuritis. It means that multiple nerves can be affected with weakness and paresthesias in the next 10 to 14 days if not treated timely. What we find in the labs on blood's complete examination, we will find leukocytosis. The blood leukocytes will be increased from 10,000 to 20,000, and the neutrophils will be more, which is called neutrophilia. Platelets usually fall down, which is called thrombocytopenia. And in more severe cases, the serum enzymes can start rising and there may be proteinuria. Protein starts coming in the urine. So it is a serious case. When we do culture, we take smear from the membrane and we send it for culture. This is diagnostic. And when we are going to start treatment, First of all, we should take a smear swab from the throat, from the membrane, and we should send it to the lab for culture and sensitivity, and then we should start treatment without waiting for the results. And then when the result comes, then we can modify our management plan. Another is a fluorescent antibody stain, which can be done, but it is not some definitive diagnosis. The cultures is the main diagnostic criteria, and the swab can be taken from the nose, from the pharynx, or wherever you find the membrane, we can take the swab. So our treatment options, first of all, this is an emergency. As I have told you, you have to admit this patient as early as possible. Isolate the patient separately, because this patient can transmit the infection through droplet to all the patients nearby. So we should keep the patient in the separate room, isolation room. Patient should be wearing mask, and any healthcare worker who goes to visit the patient should also wear the mask. So that and after visiting the patient, we should sanitize our hands or wash our hands properly to stop the spread of the bacteria. As I already told you, we should start treatment as early as possible after taking the swab. At once we should start the treatment, and antitoxins are available. We should start antitoxins for neutralization of the toxin, free toxin which is present in the blood, and to eliminate, and we want that further toxin is not produced to control the local infection. And we can also start antibiotics to prevent secondary infections. We give hydration, IV support, so the patient is not dehydrated, and we should always give intravenous medicines. Diphtheria antitoxin is usually produced from horses. It will not neutralize those toxins that has already fixed to the tissues, but it will neutralize the free toxin which is circulating in the blood, so that it can further not damage the tissues. So the early we give this antitoxin, the more chances of survival of the patient are there. So we should start as early as possible. Antibiotics I told you are given for the prevention of further toxin production and to control the spread of the bacteria. Then we have to control the local infection, reduction of transmission. Penicillin is very classical drug and very as drug of choice, which is given in diphtheria. It has chances of hypersensitivity reaction, so they have to be given very cautiously, and always give test dose before starting penicillins. And we can give also amoxicillin for at least 2 weeks, and erythromycin can also be used orally as well as by injections for at least 2 weeks. How we can prevent? We should always immunize all the children with diphtheria. As you know, diphtheria vaccine is included in the EPI schedule of Pakistan. EPI are those vaccines which are given to the children in the first 6 months of life to prevent from these diseases. Still there is chance of getting infection, but the chances are less. So it is included in the DPT vaccine, diphtheria, pertussis, and tetanus vaccine, which is given in the early first year of life. And if diphtheria occurs in some close community, All the contacts should be given prophylactically erythromycin before developing the disease symptoms, and all the contacts should be immunized and should be given a booster dose of toxoid to prevent the further spread of the disease, because it is very contagious. It can easily spread through the droplet infection, so we have to be very careful. And this is all about diphtheria. If you have any questions, you can ask in the question box. Thank you very much.